communities? What are we going to do about certain pockets of people resisting to get the vaccines? And how can we persuade them that we need to do it to make everybody safe? What's the status of the vaccine research with children? And how do we restore the CDC to its historic place at the top of the panoply of the international public health community? All of those are really important issues that we're going to have to answer. We have two people here with us today who have been extraordinary in helping us develop the vaccine and also our country's response to the pandemic. That's, of course, the now famous Dr. Fauci and also Dr. Marks, who have appeared in front of this subcommittee many times. And we want to thank both of you for your efforts. And also, we are so happy to have new leadership down at the CDC. Dr. Walensky, thank you so much for being with us. This is her first time testifying before this committee, and I know it won't be the last. We work forward to working with you to make sure that the CDC is working at its very top and science-based best. The American Recovery Act, which was just passed by Congress and signed into law last week, further will help us boost vaccinations and testing across the country. It provides funding to families, states, local governments, and business. And so we feel like the veil is lifting on COVID-19, but we still must remain vigilant. We can't become complacent now. This is a message the administration has been giving out every day. And in addition, vaccine hesitancy and access disparities persist, as I said. We have to work together to address these disparities. I want to thank the witnesses again for coming. We all look forward to hearing from you today about where we're at, where we need to go, and how Congress can help. Because if we all do our part, we can end the pandemic, and this committee will continue to do its part by continuing our bipartisan oversight over this critical subject, which we have aggressively pursued, not just since the beginning of the pandemic, but for all of the 24 years that I've been on this committee. And with that, the chair is pleased to recognize the ranking member of the subcommittee, Mr. Griffith, for 5 minutes for an opening statement.
Thank you very much, Chairman DeGette, for holding this important hearing on COVID-19 vaccines. Just over a year ago, the World Health Organization announced that COVID-19 could be characterized as a pandemic. A few days later, President Trump declared a national emergency in the United States. About a week after that, California became the first state to go on lockdown. More states followed soon after that, forcing businesses, schools, and restaurants to close. As of March 16th, we have lost over 533,000 Americans to COVID-19, and according to a recent New York Times article, 1 in 3 Americans have lost a loved one to the virus. Tens of millions more have been infected, some of whom are experiencing prolonged symptoms. However, we have reasons to be hopeful. There is light at the end of what has been a very dark tunnel. Because of the success of Operation Warp Speed and the unprecedented efforts of the private sector to date, we have 3 safe and effective vaccines that have received emergency use authorization, EUAs, from the U.S. Food and Drug Administration, FDA. Pfizer, Moderna, and Johnson & Johnson and more vaccine candidates are in clinical trials. 2 of our witnesses, Dr. Fauci and Dr. Marks, played important roles in this achievement. While the vaccine rollout was slow to start as vaccine manufacturers ramped up their production efforts, the supply and distribution has continued to improve since the first vaccines were authorized, distributed, and administered in December. According to the Centers for Disease Control and Prevention, nearly 22% of the U.S. population has received at least 1 dose of a COVID-19 vaccine, and almost 12% of the U.S. population is fully vaccinated. This means that more people have been vaccinated than have been infected with the virus in the U.S. We still have a ways to go, but we are in a remarkable situation given we are only a little over a year out from the start of this global pandemic. Recently, this subcommittee held 2 hearings focused on COVID-19 vaccines. On February 2nd, the subcommittee heard from a handful of states about vaccine distribution and administration efforts at the state level. The overwhelming message was that supply was their biggest issue. On February 23rd, the subcommittee heard from 5 COVID-19 vaccine manufacturers on the status and supply of their vaccines. Pfizer and Moderna testified they anticipated delivering 300 million doses each of their COVID-19 vaccines by the end of July. In addition, Johnson & Johnson testified it could deliver 100 million doses by the end of June. Further, other companies, including AstraZeneca and Novavax, have been manufacturing vaccine doses at risk so that doses will be available to ship should their vaccines receive authorization from the FDA. I look forward to hearing from the top federal officials before us about President Biden's recent promise that every American adult will be eligible for a COVID-19 vaccine by May 1, and how soon after that each adult will be able to make an appointment and actually get vaccinated. I also hope to get an update regarding recent guidance that has been issued by the administration, including guidance relating to schools, guidance for those who have already been vaccinated, and the recent revised guidance for nursing homes. Further, I look forward to hearing about research efforts over the past year, since what we know now about the virus is very different than what we knew 1 year ago. Specifically, I hope to hear about the status of the variants, including how effective our existing countermeasures are against the new variants, and what we know about those who continue to experience symptoms long after contracting the virus, also known as long haulers. Lastly, I hope to get an update from the FDA regarding the timing of additional vaccines being authorized and what the process will look like when the public health emergency is over and we have a transition and have to transition products that have received EUAs to full approvals. I look forward to our discussion today to learn more about the federal government's ongoing response efforts and how we can end this pandemic as quickly as possible. Thank you again, Madam Chair, and I yield back.
I thank the gentleman. Chair is now pleased to recognize the chairman of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Madam Chair. And let me initially thank the witnesses for arranging their schedules so that they could testify before the subcommittee this morning. I know how busy you all are. And obviously, as the Chairwoman Degat said, we're here today to continue our critical effort or oversight of the COVID-19 vaccination campaign in the United States. And that has great promise, really, at this point to help us beat the pandemic. We've all been working hard in Congress to help expand the availability and administration of the 3 available vaccines around the country. Last week, President Biden signed the American Rescue Plan into law, and this obviously invests in the tools and resources needed to crush the virus and provide relief to struggling families. Specifically, the bill provides more than $20 billion to speed up COVID-19 vaccination efforts across the country, supports the development of community vaccination centers, and provides funding for mobile vaccination units in underserved areas. Now, many of you know that I was critical of the Trump administration for leaving it up to states to compete with each other for testing, medical supplies, et cetera, over the last year. There was no national effort really on the part of the Trump administration. It was pretty much left up to the states. And while the initial vaccine rollout under the Trump administration was bogged down because of, in my opinion, poor planning and limited state resources and supply, the Biden administration has taken decisive action to get the COVID-19 vaccination effort back on track. Since President Biden took office, the weekly vaccine supply sent to states has more than doubled, and states have been given more advance notice of their vaccine allocation. We're now on track to have enough vaccine supply for all American adults by the end of May, 2 months earlier than prior projections. And the Biden administration also continues to prioritize efforts to ensure equitable distribution or access of vaccines for marginalized communities and Americans who are more vulnerable to severe disease. President Biden's also focused on the well-being of children and families, recognizing the need for students to return to in-person school as soon and safely as possible. President Biden has encouraged states to expand their vaccination eligibility to teachers and school staff, and he also expanded the retail pharmacy program to help vaccinate educators by providing additional doses and helping educators schedule appointments. The American Rescue Plan also provides nearly $130 billion to help schools reopen safely and support students and staff returning to the classroom. And thanks to the Biden administration's efforts, we've already seen encouraging results. More than 70 million Americans have received at least 1 dose of COVID-19 vaccine. And last week, President Biden set the aggressive goal directing states to make all American adults eligible for the vaccinations by May 1st. And I applaud the president's ambitious proposal and look forward to working with the administration to achieve this bold benchmark, obviously with all of our witnesses. Now, despite these tremendous efforts and the progress that has been made by all three of our witnesses, we can't be complacent. As the president told the American people last week, and I know Dr. Fauci keeps saying it too, I hear him all the time on the media, that the government alone cannot defeat this pandemic. It's going to take all of us doing our part to beat this virus and return to our former lives. And the stakes couldn't be higher. The longer it takes to vaccinate America, the more we risk further spread of the disease and increase the likelihood that new variants will continue to spread. So I'm pleased that we're joined today by the distinguished panel of scientists and public health leaders from the Biden administration. I look forward to hearing how we can continue to make progress and respond to the challenges that remain in the battle against the pandemic. I know that all of you are constantly out there. One of the things that I know that you continue to stress is that people should not be afraid to take the vaccine. And I don't want to stress that too much in my opening remarks now, but I still do worry when I go around. There are many people who either will tell me that they're afraid to take the vaccine or won't tell me that directly, but I know that that's what's going on in their minds. And so I know that that's an important part of the American Rescue Plan, too, is I think there's $1 billion that was part of our that Energy and Commerce initiative on the bill to basically have a program and make people aware that this is something that they should participate in. So thank you again, Madam Chair. This is a very important hearing. I appreciate it.
I thank the gentleman. Chair now recognizes the ranking member of the full committee, Ms. McMorris-Rodgers, for 5 minutes.
Thank you, Chair DeGette and Republican Leader Griffith. Thank you to our distinguished panel. First, let's set the record straight. Regarding the COVID-19 vaccine development and distribution, President Biden started on third base, yet Democrats in the media suggested that he hit a triple. We keep hearing disinformation about what President Biden inherited. The first false claim is that President Biden had to start from scratch. On January 21st, CNN reported that anonymous Biden administration sources said, quote, "We are going to have to build everything from scratch." 3 days later, President Biden's chief of staff, Ron Klain, perpetrated this claim, and Vice President Harris repeated it just last month. This is disinformation. Dr. Fauci, you publicly stated that the Biden administration did not start from scratch. The day President Biden entered the White House, more than 1.5 million new doses were administered. Let's not forget the nationally televised 60 Minutes segment with General Perna on the Trump administration's distribution plans. That was in early November, before we even had a COVID-19 vaccine to distribute. The Trump administration first outlined their plan in September. In October, the administration even announced partnerships to administer free vaccines. Another false claim is that the Trump administration did not contract for enough vaccines. On March 2nd, President Biden claimed that, quote, "The prior administration had contracted not for nearly enough vaccine to cover adults in America." Again, this is disinformation. It's false. Last year, the Trump administration entered into contracts with multiple companies to manufacture hundreds of millions of doses of COVID-19 vaccines. To date, between just the 3 companies who have EUAs, we have enough doses to vaccinate 300 million people, far more than our eligible adult population. And that's not to mention the options for purchase of additional doses included in those initial agreements, which the Biden administration appears to have recently used. I'm disappointed that President Biden and Democrats refuse to acknowledge any successes of Operation Warp Speed. Vaccines normally take more than 10 years to develop, yet we have 3 safe and effective vaccines in less than 1 year. Imagine how many lives will be saved. Every American, Democrat and Republican alike, should be proud and thankful for its success. We should be looking at this model for America to lead a new era of innovation for medical breakthroughs, not downplaying its success to underpromise or score political points. I now want to turn to school closures. Let's be clear. School closures are having a devastating effect on our children. Dr. Hassan, the division chief of pediatric infectious diseases at RWJ Barnabas Health in New Jersey, put it, quote, "The mental health crisis caused by school closing will be worse, a worse pandemic than COVID. Worse than COVID. Yet schools remain closed. 1 year ago today, this day, Governor Inslee closed the schools in my home state of Washington, and we've been too slow to open. Washington ranks 46th in the nation in getting students back into the classrooms. This is unacceptable. Why is it taking so long, Governor Inslee? It's time our kids return to the classroom. Schools remain closed because of fear and politics, not science. Dr. Walensky, on February 3rd, you stated, quote, "Schools can safely reopen." Dr. Fauci, for months last year, you agreed schools should reopen. As you put it last fall, quote, "Close the bars and keep the schools open." But unfortunately, the teachers' union continues to stand in the way. President Biden should be leading to get our schools open. But following public backlash from the White House about your remarks, Dr. Walensky, the CDC published guidance that kept many schools from fully reopening. We now know the CDC misinterpreted some of the research it relies on. 4 doctors wrote in USA Today and confirmed fear, not science, led to harmful policy. Enough is enough. Our kids are in crisis. Today, I call on you, Dr. Walensky and Dr. Fauci, to do as this administration promised. Follow science and truth. Update the CDC guidelines to open our schools immediately. Surely that's something that we can all agree on. Thank you. I yield back.
I thank the gentlelady for yielding back. The chair will now ask unanimous consent that the members' written opening statements be made part of the record and without objection so ordered. I want to now introduce the witnesses for today's hearing. Dr. Rochelle Walensky, the director of the Centers for Disease Control and Prevention. Dr. Anthony Fauci, the director of the National Institute of Allergy and Infectious Diseases. Dr. Peter Marks, who's the director of the Center for Biologics Evaluation and Research at the FDA. I just can't thank you enough, all of you, for the work you've done and for appearing today. And I know all of you are aware that this committee is holding an investigative hearing. And so when we do so, we have the practice of taking our testimony under oath. Does any of you have an objection to testifying under oath today? No. Let the record reflect the witnesses responded no. The chair then advises you under the rules of the House and the rules of the committee, you are entitled to be accompanied by counsel. Does any of you wish to be accompanied by counsel?
No. No.
Let the record reflect that the witnesses have responded no. If you would, then please raise your right hand so I may swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
I do.
Let the record reflect the witnesses have responded affirmatively, and you're now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. The chair will now recognize our witnesses for 5 minutes for their summary of their written statements. As you can see, there's a timer on the screen that'll count down your time, and it turns red when your 5 minutes has come to an end. So first I'd like to recognize Dr. Walensky. Doctor, you're recognized now for 5 minutes.
Good morning, and thank you, Chairwoman DeGette and Ranking Member Griffith, for your invitation to talk with you today and for your leadership during the U.S. response to COVID-19. I have had the honor of being the director of the Centers for Disease Control and Prevention for 2 months. Taking on this role in the middle of a pandemic has presented no shortage of challenges, and I am so grateful for the guidance of the dedicated staff at CDC and the deep expertise they bring. CDC staff continue to work tirelessly to respond to the COVID-19 pandemic, and I am committed to supporting their efforts to ensure that science and evidence drive our path forward. Last week, we crossed the 1-year mark since the WHO declared COVID-19 a global pandemic. I want to take a moment to recognize the more than 500,000 American lives lost during this past year. That is 500,000 mothers, fathers, sisters, brothers, grandparents, and children who have died because of this virus. Every loss is felt by grieving families, by friends unable to say goodbye, and by communities devastated by this pandemic. While we have recently seen reductions in cases and deaths, we must remain cautious. The average daily death rate is tragically still more than twice that seen last September. We are in a race to stop transmission, and the emergence of variants that spread more easily has made that even more challenging. I am committed to closely monitoring the proliferation of these variants in our country and around the world. We are doing that by rapidly scaling up genomic sequencing, and we are well on our way to 25,000 samples per week. As we monitor disease transmission and variants, we are getting vaccines into arms quickly, safely, and equitably as possible. Having 3 vaccines that are highly effective at preventing serious illness, hospitalization, and death will help us end this pandemic. As of March 16th, more than 110 million doses of COVID-19 vaccine have been administered. Over 72 million people have received at least 1 dose, including more than 39 million people who are fully vaccinated. This is a remarkable accomplishment, and yet we have so much more work to do. CDC is working in coordination with national, state, tribal, and local governmental and non-governmental partners to build trust in the vaccines, the vaccinators, and the vaccination system. Instrumental to this work is addressing barriers to vaccinations in communities of color and disproportionately affected groups. COVID-19 has highlighted long-standing systemic health disparities, and health equity must be a cornerstone of our public health work. CDC is committed to expanding evidence-based approaches to reduce disparities in COVID-19 cases, hospitalizations, and deaths, prioritizing equity in vaccine distribution, and expanding a diverse workforce. This is not our first emergency. Since 2009, the U.S. has faced 4 significant emerging infectious disease threats: the H1N1 influenza pandemic, Ebola, Zika, and now COVID-19. While urgency demanded rapid and unique approaches in response to each of these threats, none resulted in the necessary, sustained investments in public health infrastructure. This lack of preparation continues to present significant challenges in our ongoing fight to tackle COVID-19. If we don't act with permanent fixes, these challenges will continue to exist when the next public health threat emerges. I would like to leave you with 4 important points today. First, CDC is leading with science and will continue to be the public health scientific resource for the American public and our international partners. Second, we are expanding the reach of life-saving COVID-19 vaccines and improving vaccine confidence. To end this pandemic, we must also maintain proven effective prevention measures, mask and hand hygiene, and physical distance. Third, health equity must be at the intersection of everything we do in public health, and I am committed to doing that as CDC director. And finally, we must work towards sustainable investments in public health infrastructure to be better prepared for whatever comes next. I look forward to working together to address both the immediate challenges ahead and addressing the deficiencies in our public health infrastructure that left our country vulnerable to this pandemic. We will get through this pandemic, and I look forward to working with you to support CDC and address our public health challenges at home and abroad. Thank you again for this invitation to testify today, and I look forward to answering your questions. Thank you
so much, Dr. Thank you so much, Dr. Walensky. I'm now very pleased to recognize Dr. Fauci for 5 minutes.
Thank you very much, Madam Chair, Ranking Member Griffith, Chairman Pallone, Madam Chair McMorris Rogers, thank you for giving me the opportunity to present to you the role of the National Institute of Allergy and Infectious Diseases in research addressing COVID-19. I had some slides there, but we better go without slides. I think it will be better given this virtual nature of it. The NIAID strategic plan includes 4 major components: improving fundamental knowledge, developing diagnostics, characterizing therapies, and developing safe and effective vaccines. Let's start off first with the characterization and the testing of therapeutics. There are 2 major ways of approaching this. One, therapeutics for early to moderate disease, and 2 therapeutics for moderate to advanced disease. We've made substantial progress in randomized placebo-controlled trials that have led to the FDA approval of a drug called remdesivir, which is playing a major role in the treatment. EUAs have been given for monoclonal antibodies from Lilly and from Regeneron. Convalescent plasma has an EUA, and other antivirals and hyperimmune globulin are being actively tested. With regard to therapeutics for moderate to advanced disease, dexamethasone is the standard of care and has been shown in a randomized placebo-controlled trial to diminish significantly the 28-day mortality of people in the hospital on respirators or requiring high-flow oxygen. In addition, an emergency use authorization has been given for baricitinib plus remdesivir. I want to point out that one of the most important advances that we will be pursuing over the coming months is the identification of vulnerable targets in the SARS-CoV-2 replication cycle, very similar to what we did with the highly successful development of drugs for HIV and the curative therapies for hepatitis C. When you develop and show the replication cycle, you can identify vulnerable targets and design drugs to inhibit these vulnerable targets. And then we have vaccines. Perhaps the most important success story in this terrible outbreak that we've been experiencing has been the success with vaccines. But this did not start in January when the virus was recognized. It began with research decades earlier, particularly within the NIH and particularly within the Vaccine Research Center, where basic preclinical and clinical research to develop vaccine platforms like mRNA and vector-borne expression of protein. In addition, the stabilization of the spike protein at the NIH Vaccine Research Center by Dr. Barney Graham and his colleagues serves as the basis for 5 out of the 6 vaccines that have now been either tested or already proven to be efficacious. In addition, the NIH has utilized and pivoted its extensive domestic and international clinical trials network that we set up decades ago for HIV and influenza. As you well know, and as was mentioned in some of the opening remarks, we now have 3 vaccines that have been proven to be highly efficacious and safe: the Moderna, the BioNTech Pfizer, and the J&J. And we soon will be getting data from AstraZeneca and Novavax. One thing to point out about the development of this vaccines, that it has been done in record time. The sequence of the virus was put on a public database on January 10th. 65 days later, a phase 1 trial started. And on July 27th, 2 of the 3 vaccines, the Moderna and the Pfizer, began a phase 3 trial. And within a period of a total of 11 months, vaccine was going into the arms of individuals that was highly efficacious. And it should be pointed out that there was no cutting of corners, that this was just a reflection of the extraordinary scientific advances. And finally, we must deal with viral variants, which are mutational changes in the virus, which have been a source of discomfort and concern among many nations throughout the world. We will address them by enhancing our vaccination programs against the wild-type virus, by boosting with variant-specific viruses, and, as we mentioned over and over again, by implementing the public health measures of masks, distancing, avoiding congregate settings, and washing of hands. I'd be happy to answer questions later. Thank you very much, Madam Chair.
Thank you so much, Dr. Fauci. I'm now very pleased to recognize for his, before I do, Dr. Fauci, it's never a presentation by you without slides. So if you can provide the slides to this committee, we will distribute them to all of the members.
I will do so, Madam Chair. I had them. I just thought by showing them it could be, but you will get copies of them. I assure you.
Thank you so much. We look forward to having you back in person with your slides later this year. I'm now very pleased to recognize Dr. Marks for 5 minutes.
Chair DeGette, Ranking Member Griffith, distinguished members of the subcommittee, I'm Peter Marks, Director of the Center for Biologics Evaluation and Research at the U.S. Food and Drug Administration. Thank you for the opportunity to testify before you today to describe the and response efforts. All of our efforts are in close coordination and collaboration with our partners across the federal government to help ensure the development, authorization, or licensure and availability of safe and effective medical products to address the COVID-19 public health emergency. While my testimony will focus on FDA's work regarding COVID-19 vaccines, I want to note at the outset that this is in the context of the breadth of work that we're doing across the agency to address the pandemic, including our efforts on diagnostics and therapeutics. With the urgency called for during this pandemic, FDA, through our transparent scientific review process, has provided emergency use authorization, or EUA for short, for 3 COVID-19 vaccines. In doing so, we've relied upon the agency's rigorous standards for safety, effectiveness, and manufacturing quality. Normally, vaccine development is a slower process in order to minimize risk. The process proceeds sequentially through the various stages of clinical development, and manufacturing scale-up only takes place when it's very clear that the vaccine has been shown to be safe and effective and is on track for regulatory approval. These vaccines were developed without cutting corners or sacrificing our standards by intensive interactions between FDA and manufacturers, eliminating the time between different studies in the clinical development process, merging together different phases of clinical trials, and by simultaneously proceeding with manufacturing scale-up at risk before it was clear that the vaccines would be shown to be safe and effective while the clinical trials were ongoing. For the 3 vaccines authorized to date, our EU process not only included a thorough evaluation of the data by the agency's career staff, but also included input from independent scientific and public health experts serving on our Vaccine Public Advisory Committee. Throughout this process, FDA took steps to facilitate transparency, including posting briefing documents and key decisional memoranda. The 3 authorizations make available COVID-19 vaccines in the United States that have been shown to have clear and compelling efficacy in large, well-designed phase 3 trials that meet FDA's rigorous standards for safety and effectiveness. Vaccines will help us in the fight against this pandemic, which has claimed over 500,000 lives here in the U.S. alone. All the COVID-19 vaccines authorized by FDA for emergency use have surpassed the standard of being at least 50% more effective than placebo in preventing COVID-19, which was the standard recommended in our June 2020 guidance document on the development and licensure of vaccines to prevent COVID-19. All have proved extremely effective at preventing hospitalization and death that can result from COVID-19 complications. Though there may be some differences in the results obtained using the 3 authorized COVID-19 vaccines, it should be noted that they were not compared head-to-head in a clinical trial. All 3 were found by FDA and its external advisory committee to exceed the standards for an EUA that we articulated in guidance, and importantly, all did an excellent job in preventing hospitalization and death from COVID-19. FDA also plays an integral role in the monitoring of the safety of authorized COVID-19 vaccines. FDA is doing so in collaboration with the Centers for Disease Control and Prevention, the Centers for Medicare and Medicaid Services, Department of Veterans Affairs, and other academic and non-government healthcare data systems. In addition, FDA actively participates in ongoing international pharmacovigilance efforts, including those organized by the International Coalition of Medicine Regulatory Authorities and the World Health Organization. These efforts are in addition to the pharmacovigilance efforts being undertaken by the individual manufacturers of the authorized vaccines. Given the importance of passive and active safety monitoring, a coordinated and overlapping approach using state-of-the-art technology has been implemented. These systems can also potentially be leveraged to assess safety in specific populations and to assess vaccine effectiveness, including against emergent variants. The emergence of such virus variants raises new concerns about the performance of the authorized vaccines against these variants, as well as for the therapeutics and diagnostics FDA has authorized for COVID-19. In February 2021, we issued 3 new guidances and an update to our vaccine EUA guidance to address the emergence of SARS coronavirus 2 variants. In issuing these, we want the American public to know that we are using every tool at our disposal to fight this pandemic, including pivoting as the virus adapts. These guidances will help manufacturers develop medical products to provide healthcare providers with the best available diagnostics, therapeutics, and vaccines to fight this virus, even as variants emerge. We remain committed to getting these life-saving products to people at the front lines. Having 3 vaccines authorized by FDA only 1 year after the declaration of a public health emergency is a tremendous scientific achievement and a testament to the dedication of a multitude of partners, including FDA's career scientists and physicians, many of whom have been working tirelessly to conduct comprehensive and rigorous evaluations of the data submitted for vaccines to prevent COVID-19. All those working at the agencies are grateful to be able to contribute measurably toward bringing this pandemic to an end. Thank you again, and I look forward to responding to your questions.
Did we lose Madam?
Did we lose? This is Congressman Pallone. I don't know if we lost Diana again. I mean, I could start. Can you guys all hear me?
Yes, we can, Chair.
I mean, do you think I should just proceed and ask my questions first, maybe?
Why don't you go ahead, Mr. Chair? As Vice Chair, I'll authorize you to do that.
Okay. All right. Let me just say, I don't want to prolong this because I want to ask a question of each of our witnesses. But, I wanted to stress that, when I'm critical of the Trump administration, it was based on what I had to deal with. In other words, I really felt that they did not see this as a national strategy, that they felt that the states were on their own. And many times when I had to talk to the people in charge of Operation Warp Speed, I would say, well, look, we're doing what we're best to get materials and supplies from China or other places. But this is supplemental. The states have to do this, and we're just, supplementing. We'll help them out when we can. And I just felt that that was wrong. And it's quite clear when you're dealing with the Biden administration that they see this as a national strategy, something that's coordinated nationally, and that's, obviously coordinated with the states. But it's their responsibility. And that's what I thought was very much lacking with the Trump administration and led to a lot of the problems in getting things out, whether it was supplies for testing, contact tracing, or ultimately the vaccine. But in any case, let me start with Dr. Walensky. As you know, the American Rescue Plan provides more than $20 billion for vaccine distribution and administration, including $1 billion to strengthen vaccine confidence. It also provides nearly $130 billion to get students back in the classroom. And it also has major money for public health infrastructure, which I know you mentioned as well. So my question is, how will the resources provided in the American Rescue Plan help speed up vaccination efforts across the country and particularly help schools reopen safely? And you got about a minute because I want to get to the other two witnesses. Sorry.
Great. Thank you so much for that question, Mr. Chairman. We are working really closely with the states to scale up vaccination efforts. As part of those efforts, we're working to mobilize trusted messengers, mobilize grants to national organizations, 20 national organizations to work with community-based organizations, with faith-based organizations to ensure that those trusted messengers can get to people. Last month, we had a vaccine forum with over 13,000 participants that really talked about key ways that people are reaching those hard-to-reach populations. We're giving resources to rural communities, to urban communities, to federally qualified healthcare centers so that they can reach the more marginalized communities. So we're really scaling up those vaccine efforts and with a real equity focus. With regard to schools, we are working towards distributing resources both in how we can give more resources for space, as well as for ventilation systems, as well as for testing resources. So lots of resources headed in the direction of schools as well.
Yes, Dr. Marks, the American Rescue Plan also invests more than $6 billion for research, development, production, and purchase of vaccines, therapeutics, and ancillary supplies, including $500 million for FDA activities such as the evaluation of the vaccines, facilitation of related inspections, continuous manufacturing. How will this funding support FDA's COVID treatment and vaccine efforts, particularly considering the new variants spreading across the country?
Thanks very much for that question, Mr. Chairman. We are going to be using our large database surveillance systems, which are able to look at millions and millions of lives, to be able to look at the safety and effectiveness of these vaccines. We'll be able to assess, besides making sure we have very good safety surveillance, we should be able to look at how variants may be spreading across the country, and that will help us to understand how best to interfere with and address this virus. We also hope that and are very grateful for the opportunity to do additional work in advanced manufacturing that will help us to prevent being behind the 8 ball when we have to scale up for future pandemics.
And last, Dr. Fauci, the question that's on the top of a lot of parents' minds around the country is that none of the vaccines currently available are authorized for adolescents under 16. So when do you anticipate younger teens and children will be able to get vaccinated? And in the meantime, does the lack of inoculation affect our ability to contain the pandemic? In other words, do parents have confidence sending their kids back to school knowing that they are not being vaccinated?
Thank you very much, Mr. Chairman. Yes, as a matter of fact, there are studies that are ongoing right now, both for high school age children as well as for elementary school age children. The way these tests are now designed to give safety and what we call comparable immunogenicity, we will not have to prove in an efficacy trial that they work. We just need to show that it's safe and that it induces a comparable immune response that we know correlates with protection. For high school students, it looks like they will be available to get vaccinated in the beginning of the fall, very likely for the fall term. With regard to children, we're doing an age de-escalation study in elementary school children from 12 to 9, 9 to 6, 6 to 2, and 6 months to 2 years. We anticipate we'll have enough data to be able to vaccinate these younger children by the first quarter of 2022.
Thank you. I guess we should go to Morgan Griffin next, although I see that Diana's back. Do you?
Thank you, Mr. Chairman, and I really do apologize. I've got 2 computers that keep going out, so I appreciate everybody working together, and I appreciate you, Mr. Chairman. We will now recognize the ranking member, Mr. Griffith, for 5 minutes.
Thank you very much, Madam Chair. As I start, let me say, Dr. Lewinsky, thank you for getting us some questions answered related to school opening that we sent you. We got those answers last night. I haven't had time to go through them fully. I do know there's still some outstanding questions, and we will probably have some follow-up. That being said, President Biden recently announced that he will direct states to make every American adult eligible for COVID-19 vaccines by May 1. This is exciting. However, eligibility is very different than accessibility and shots in the arm. What is the administration's projection for when every American adult who wishes to be vaccinated will be able to be fully vaccinated?
Thank you so much for that question. There are numerous resource constraints that have been a challenge with regard to rolling out vaccines. So among them has been resource money itself, but also the vaccine itself. We know now that we will have adequate supply of vaccine for every American who is interested by the end of May, which I think is a really critical, important resource to know that we have. But that's not the only resource we need. We need to have actually vaccinators. We need to have places where people can get vaccinated, and we need to have people who want to roll up their sleeves to get vaccinated. So that is a work that we have ahead. The people who've rolled up their sleeves for the 110 million doses that have already been given are people who are anxious to get vaccinated. But we have a lot more work to do in terms of distribution.
So you would say sometime in June probably, because if there's plenty of supply by May 31st. Then probably everybody should be able to get it in May or early June. Is that a fair statement?
I'd be reluctant to put a date on exactly when we will have enough of the vaccinators and vaccinated.
Let me move on because I got limited time, and I know you do too. Dr. Fauci and Dr. Marks, recent reports have indicated a rift has developed between countries, particularly some in the EU, but other countries as well, which have approved the use of the AstraZeneca vaccine and they're seeking additional doses. The Biden administration, in the meantime, has been stockpiling doses of the AstraZeneca vaccine, waiting for the emergency use authorization from the FDA in the United States. Now, I'm not going to fuss at the FDA because they got to make that decision. That's their job. But I am curious about, how old is the AstraZeneca stockpile now, and when does it expire? I know it has a 6-month life, so how old is it, and when are we going to run into the risk of actually throwing some vaccines away that if we don't want to use them, somebody else might want to? Dr. Fauci, do you want to start with that? And then Dr. Marks, anything you want to add?
Yeah, let me just, Congressman Griffith, address the issue of the AZ and the issue in Europe. Right now there's a big conflict in Europe where many of the countries do not want to use the AZ vaccine. We have a situation where the European Medicines Agency, the EMA, has indicated very, very clearly that they feel that this is not an issue with regard to the supposed adverse events of blood clotting. So they feel that it should be used, even though many of the countries are not using them. We in the United States have an ongoing trial that's fully enrolled with the AZ product. And as you mentioned correctly, within a reasonable period of time, as we get into April, there would likely be enough data to be able to make a determination as to regard to the EUA. With regard to the expiration, I would have to refer that to Dr. Marks because the FDA knows more about that than I do.
All right, and since you brought up the blood clotting, before you get there, Dr. Marks, I did some math, and somebody correct me if I'm wrong. In the UK, they've given out 17 million doses of the AZ and had, according to my math, 0.002% folks with blood clotting issues and having had coronavirus and then had blood clotting without having taken any vaccine. Is that unusual?
I think
to me that's an unusual amount.
Yeah, I think that's the point, Congressman Griffith, that the European Medicines Agency is making, that the actual incidence of the clotting is not more than you would expect in the population in the absence of vaccine. So that's why they're insisting that the concern is not founded on the reality of what's gone on.
My time is almost up. Dr. Marks, can you tell me what are we doing with this stockpile, and is it going to go bad, and are we going to throw away doses that could be used for countries that do want the vaccine, even whether it be the EU or other nations?
So the EU, when they approve this, put an expiration date, but we do not necessarily have expiration dates on products under investigation and drug applications when they are maintained on stability studies. And so I do not believe at this time we are at risk of throwing that vaccine out anytime in the near future.
But you do hope that we'll get approval soon, or you hope that if it works out and the FDA appropriately approves it, that we would have those vaccines for Americans then?
That's correct.
All right. Thank you very much. I yield back. Thank you, Madam Chair.
I thank the gentleman. Chair now recognizes herself for 5 minutes. As I said in my opening statement, this committee has long been concerned about pandemic preparedness. And in fact, we had a hearing on December 4th, 2019, just before COVID-19 hit. Of course, it wasn't about COVID-19, but it was about pandemic preparedness. And at that hearing, I asked then HHS's Assistant Secretary, well, I asked everybody, and one of the witnesses said, what keeps them up at night? And one of the witnesses said his biggest fear was a pandemic, quote, that could devastate our country through our health and our economy and our social institutions, end quote. That was just shortly before COVID hit. Now, Dr. Fauci, you were on that panel that day, as I said, and you've testified with your slides at many of our previous pandemic hearings. That day, you and I discussed the need to modernize vaccine development and how Congress could aid in those efforts. So I want to go back to that and say, with all of the knowledge now that we've gotten in the year plus since that hearing, I want to ask you what's keeping you up at night right now, and what can Congress help you and the agency do as we move forward in the coming months?
Thank you for that question. What is keeping me up at night is the same thing that I actually also answered that question of yours back then, that it was a respiratory-borne virus that has a high degree of capability of spreading and that has the capability of causing a high degree of morbidity and mortality. We are still in the middle of a serious outbreak. And one of the things I get concerned about, both for the present and for the future. For the present, it's that we prematurely pulled back on our mitigation methods. We now have stabilized at a plateau. We had a sharp decline and a decrement of cases after that extraordinary spike that we saw, where we were seeing anywhere between 300 and 400,000 cases per day and up to 3,000 to 4,000 deaths. Well, luckily and happily, it's gone down. However, we plateaued at around 50,000 cases a day, an unacceptably high level. My concern is that we prematurely pull back and don't give the vaccines time to continue to protect the country. With regard to the future, and your question that you asked, my concern is that we don't have the corporate memory of lessons learned, and we don't look at what happened to us here and the things that we need to do in the future to prevent this from happening again. But thank you, because the Congress has been extraordinarily supportive of what we've done. And in fact, many of the successes of the vaccine related to the long-standing decades of support that we've received from the Congress.
Thank you. Thank you so much. Dr. Walensky, as CDC director, you lead our public health response to COVID-19. As we just saw in the press over the last few days, in the last Congress, a number of the CDC's recommendations were either subverted in the last administration or they were influenced by non-science-based principles. What's the CDC doing to restore science back to the findings and the recommendations at the agency?
Thank you so much for that question. So my first job, as you have noted, has been to ensure that we had a full review of our guidance and to make sure that the guidance that stood on the CDC website was science-based. It was written by our own scientists. That review was conducted by Dr. Ann Schickett, my principal deputy, and by the incident managers who served during this pandemic. That guidance, during that process, we have taken down some of the things that were previously put up that were not authored by CDC personnel as well and scientists, as well as came up with some recommendations in moving forward to ensure that our guidance has executive summaries, has end users that can understand it, that has scientific briefs that accompany it, and we are working towards making sure that all of our guidance moving forward will follow those recommendations.
Thank you so much. And Dr. Marks, turning to you, as more Americans get vaccinated and we get more real-world data about the effectiveness of the authorized vaccines, how is that going to inform future decisions about use of vaccines, including whether we need boosters or changes to address the variants that we're seeing crop up all around the world?
Thanks very much. So as we have real-world evidence that comes in, we'll be analyzing it. We'll be looking to make sure that we have continued protection against these viruses that are circulating. We'll also be looking at the trials that continue to see how long people who were enrolled in the trials are maintaining their immune response. So that combination of evidence from people who were enrolled in the trials and continue to be monitored, plus the real-world evidence together will give us what we need to understand when we may need to come out with a booster of some sort.
And just very briefly, because I know people want to know, when do you expect to start getting results from that real-world evidence?
So we are already starting to get the first readouts from the large databases that we are having for safety. Effectiveness data will come later on, but the safety data are just starting to come in now.
So you think the next few months?
Yes.
Okay, thank you so much. Chair is now delighted to recognize the ranking member of the full committee, Ms. Rogers, for 5 minutes.
Thank you, Madam Chair. Our kids are in crisis. Suicide risks are up, overdoses are up, the mental health related visits are up. Dr. Hassan, the division chief of pediatric infectious diseases at RWJ Barnabas Health in New Jersey, put it, quote, "The mental health crisis caused by school closing will be a worse pandemic than COVID." So my first question, yes or no, Dr. Walensky, do you agree that the mental health crisis caused by school closures is a public health crisis?
Thank you for that question. I would comment that I too am concerned about the mental health of our children, and I am working very hard to get our schools open. And I think we will have a lot of work to do to address the mental health challenges and the educational challenges of this past year.
Is that a yes, Ben?
I think it would be hard to pit one crisis over another. So I would just say I think we have challenges in both areas.
So we know that CDC's guidance requires 6 feet of separation, which is a significant obstacle for schools to reopen. I've heard it in Eastern Washington, and I know others have heard it across the country. That guidance doesn't seem to be weighted on scientific evidence. So I'd like to ask Dr. Walensky, in your home state already it allows 3 feet. Colorado allows 3 feet. The WHO advises one metric, basically 3 feet. The Harvard T.H. Chan School of Public Health cites 3 feet. The American Academy of Pediatrics says 3 feet is sufficient. The CDC even published a study at the end of January that showed minimal in-school spread with students not maintaining 6 feet of distance. And before joining the CDC, you yourself agreed that 3 feet is safe. I have an email here. So this is back in 2020, July 2020, that you advised your hometown mayor that, quote, if people are masked, it's quite safe and much more practical to be 3 feet. So to address what I believe is a mental health crisis, Dr. Walensky, our schools need to be opened. The school closures is causing a mental health crisis. We need swift action from the CDC. And I don't think that we need to wait for more studies. So yes or no, if people are masked, is it safe and more practical to open schools with the 3 feet of distance?
Thank you for that question. First, I want to comment that the email that was written in 2020 indeed was during a time when we had very little transmission, or about 40,000 cases. The guidance that came out happened in the context of around 200 to 300,000 cases, and before and after we were starting to talk about variants. The Wisconsin study that you report in, that you comment on in the MMWR, was exactly where we were leading into our operational guidance. As noted in that study, there were 92% of mask wearing, as well as de-densified classrooms with somewhere between 11 to 20 students in those classrooms. So our operational guidance was intended to lean in to do exactly what Wisconsin was doing. And in fact, we have surveys from the that are reported in the MMWR that said high school students are wearing their masks only about 60% of the time. So our guidance was really intended to lean in so that schools could open and act exactly like Wisconsin. We also have an MMWR report that I'd be happy to get to you from Georgia that showed where students were not leaning in, where classrooms were dense. There were outbreaks in 9 elementary schools. So our guidance was intended to lean in towards how Wisconsin was acting so that we could get our schools back safely. Now, you raise a really important point, and that is this 6 feet versus 3 foot question. As soon as our guidance came out, it became very clear that 6 feet was among the things that was keeping schools closed. And in that context, science evolves. So there has been one study that was published late last week that demonstrated in Massachusetts, where there's generally 100% mask wearing, that 3 feet was actually safe. Student rates and teacher rates of disease were the same in 6 feet versus 3 feet. There are several other emerging studies that I am aware of. As we look at those studies in the context of Massachusetts, this Massachusetts study, we are looking to update our guidance. Thank you.
That's good news. I would urge you to act, and act now. I don't think that we need to wait for additional studies. I'm a mom of 3 school-age kids. I'm speaking for millions of moms across this country that are extremely concerned about the mental health of our children. And I hear these stories every day, and I know others do too. The CDC can update its guidance. And I would just ask, when are you going to be able to do that?
We are actively looking at the additional studies. We have only one published study to date. We're actively looking at those additional studies, and we're looking to do it soon. I would just articulate, I too am a mother of 3, one who's been homeschooled the entire year. So I am entirely with you that we need to get our children back.
Now is the time. Okay, I yield back. Now is the time.
Thank the gentlelady for yielding back. Chair is now pleased to recognize Ms. Custer for 5 minutes.
Thank you very much, Chair DeGette. And I just want to say the record, we all want our children to get back to school. This is not a partisan issue. Everyone wants our children to get back to school, and we just want to be safe about it. So I'm going to turn the attention to the issue of long COVID. Some call it long hauler COVID. And for months, we've heard reports about people, Americans across this country, suffering from COVID-19 for many, many months. My own niece, formerly a world-class ski racer, she was on the United States ski team. I'm so proud of her. She became sick with COVID last April and continues to this day, almost a year later, to have trouble with the simplest of daily activities. She has to choose between taking a shower or cooking dinner. She doesn't have the energy to do both. She's 34 years old and previously extraordinarily not only healthy, but an amazing athlete. Laurel has seen so many doctors over the last many months, adding up to thousands of dollars of out-of-pocket expenses. She's gone through endless testing, and none of which has been helpful in identifying exactly what she's suffering from. And she is not alone. According to the National Institutes of Health, more than 50% of COVID-19 patients experience lingering symptoms longer than 90 days after recovering from the initial infection. Dr. Fauci, I was so pleased to see NIH's announcement last month that it had launched a nationwide initiative to identify the causes and ways to prevent and treat long COVID. What do we know so far about what causes or prevents long COVID, how we can treat it, and how long these symptoms might last?
Thank you very much for that question, Congresswoman Custer. This is a very important issue that we take very seriously. The first thing we can say, this is real. This is not imaginary. These are people whose symptoms are real. And as you mentioned, it's really variable. Different studies say anywhere from 25 to over than 35, 40% of individuals have prolongation of symptoms that measure not only in weeks, but in months, some of which, as your subject that you described, become completely incapacitating. What we need to know first, and that was the study that we announced just a short while ago, we need to know the extent of this, the percentage and the duration of it. Underlying this seems to be a commonality of symptoms, just as you mentioned very correctly. Profound fatigue, muscle aches, temperature dysregulation, unexplainable tachycardia, and what people refer to as brain fog, which is just a strange feeling of being unable to focus or concentrate for any period of time. The NIH has been now given an appropriation of $1.15 billion to study this disease, and you will be hearing more announcements, not only to understand the scope of the cohort, but the underlying cause and what the mechanisms are. We call that pathogenesis. Once we understand that, then we can start talking about designing therapies. But it is a very disconcerting syndrome that I believe is going to have effects that will go on well beyond the control epidemiologically of this syndrome. Thank you.
Well, thank you. And I wanted, just for the record, tachycardia, is that she gets a tremendous chest pain? Is that the word?
She gets a rapid beating of her heart that's unexplained. Usually when you exercise, your heartbeat goes much quicker. They're lying in bed and their heart rate is 110, 105, 115, which is distinctly abnormal for someone who's sitting down or in bed.
So I saw the first headline today that I've ever seen that maybe the vaccination might help. She's getting her first vaccine this week. Have you heard any connection about that? And is that anything that will be studied?
That will be studied, Congresswoman Custer. The issue is, thus far, that's anecdotal. And the reason I say anecdotal is that many people spontaneously get better anyway. And if you get vaccinated and you get better, you're not sure whether it's the vaccine or the spontaneous recovery. So you'll have to do a randomized trial in order to determine that.
Great. My time is almost up, but Dr. Walensky, is the CDC also working on this long COVID, and how will you coordinate with NIH in that effort?
We are. Thank you for that question, Congresswoman. We are actively doing evaluations. We're doing studies. We're collecting cohort data, and we will report those data as they emerge.
Well, we will anxiously await it. Thank you for all that you're doing. We're very grateful. And with that, I yield back, Madam Chair.
I think the gentlelady is Mr. Burgess here. I see his desk, but I don't see him. Going once, going twice.
Madam Chair, we have a conference going on, and he may have gone to that. If we could pass him by now and come back to him later, I'd appreciate it.
Okay. Mr. Long? Mr. Dunn, I know you're here.
Good. I didn't expect to be pushed up so much. Well, thank you very much, Madam Chair. So if I can start with this, you surprised me. I'm proud of the vaccine story here in the United States. There's no doubt that the early actions taken by the Trump administration to organize Operation Warp Speed, invest in manufacturing capacity, plan for vaccine distribution led to the success we see today. I'm also pleased with the current administration following through on the success, with President Biden's pledge that all American adults will be eligible for COVID-19 vaccines by May 1st. As we approach that date, I want to be sure that the administration is focused on issuing guidance that will allow more sectors of our economy to reopen. I also strongly encourage the administration to pursue policies that get our teachers and children back in the classroom. All of the schools in my district are open for in-person learning safely and with great success. And I have some serious concerns about the near and long-term effects on the children who've been kept out of their school settings for so long. Another concern is staying on top of COVID-19 variants and exploring countermeasures such as booster shots and therapeutics to combat COVID-19 infections. I think we've not given enough attention.
So they passed over to you, been done, and then
to antiviral therapeutics. In that vein, the medical community needs to also better understand the COVID-19 immunity, who has it and for how long. We know how to test for T-cell, that's humoral immunity, but the testing is complex, not widely available. There's been a lack of emphasis on this type of testing, and we've already spent $6 trillion, it seems to me. A test for immune status needs our attention, honestly. Dr. Fauci, according to media reports, 2 federal health officials at the CDC discussed changing the travel recommendations for those who were fully vaccinated against COVID-19, but abandoned the idea because there was never a lot of momentum behind adjusting it. Is that accurate? And if so, why is momentum driving these decisions rather than science?
Well, I would leave the answer to that to Dr. Walensky, but let me just say that from my own standpoint, the CDC has come out with the first of an installment of recommendations related to what vaccinated people can do. That was a short while ago, talking about in the home type of interaction with vaccinated people as well as with unvaccinated people. But the rollout of further recommendations, I'll leave that to Dr. Walensky. Rochelle?
Dr. Walensky?
Thank you very much. We had internal conversations as we were rolling out guidance for what you can do with vaccination about what we should say or do about travel. Those never hit pen to paper. There were conversations among subject matter experts as to what should happen. And in fact, I never saw a draft of that. I don't believe there ever was a draft of that. As you may recall, that at the time that we released that guidance just last week, I believe, just 9% of Americans were vaccinated. We're now up to fully vaccinated. We're now up to about 11%. We're revisiting the travel question. That's a really key question.
So because we're short on time, I'm going to interrupt you here and ask another question for both Dr. Fauci and Walensky. I'm concerned about the vaccination rate of dialysis patients. Okay, this is clearly the most vulnerable patients. And we know that, and yet somehow they've been overlooked in the prioritization. So we have 1.6 million dialysis patients and staff across the country that are awaiting vaccination. It seems to me that they would be pushed to the front line. Can either of you address that for me? Make me more comfortable?
Yeah, thank you for that question, Congressman. CDC is actively working to support the development of a vaccination program within dialysis centers. You're right to highlight that this is a key high-risk population among many other high-risk populations, and we're working actively to ensure that that can happen. I'm happy to provide you an update.
And this group, by the way, these patients, they have enormous penetrance on vaccination. So they typically get 95% annual flu vaccinations and things like that. These doctors are very attentive. They see their patients 3 times a week anyways. I mean, it seems like, that would be a group that we could actually focus on.
And I would add to that a high-risk minority population as well. So we have a lot of motivation to try and get that group vaccinated.
So in the last 15 seconds, Dr. Fauci, what percentage of people who are eligible, early COVID patients who are eligible for monoclonal antibody therapy, actually get it now in the country?
Yeah, a very small percentage, because as you know, we have about 50,000 new infections per day, and the amount of monoclonal antibodies are measured in the hundreds of thousands to a million. So when you're talking about relative percentage, Congressman Dunn, it's extremely small. And we're trying to make sure we can get people early enough in the course of their infection to get it. We know that, right? Yeah. We know now that it does not work after they get into the hospital. You need to get them early on. And there's a logistic issue there because of infusion centers are not readily available for people. So you want to get somebody early, but you have a technique that requires an intravenous infusion, which it makes it logistically difficult.
Well, I appreciate you working on that, and I yield back, Madam Chair.
I thank the gentleman. Chair is now pleased to recognize Ms. Rice for 5 minutes.
Thank you, Madam Chair, and thank you all for being with us here today. Dr. Walensky, you mentioned in your opening remarks about the deficiencies in our public health infrastructure that all of us on this Zoom today have seen in our own districts. But I think it's really important, and I'd ask you to kind of expound on that, because what we need to do is make sure that, God forbid, we have a situation like this pandemic again, that with all of this major federal money, taxpayer money going to address this pandemic and improve our infrastructure across the board, that the money is going in the right place and we're building back smarter and with more of an eye towards resiliency. So if you could just expound on what you meant by the deficiencies.
Thank you so much for that question, Congresswoman. There's been a study that came out of TIFA that looked at a survey and demonstrated that over 50,000 public health jobs have been lost in the last decade, all during the time when we have experienced outbreaks of H1N1, Ebola, Zika, and now, of course, COVID-19. I think part of that public health infrastructure really does need to be in the workforce itself. We need to develop a workforce. Just in this last year, hundreds more have left the workforce because of exhaustion and threats. So we need to develop the workforce. Secondly, we need to develop the epidemiology and data monitorization. I've spoken to public health epidemiologists and labs that say that they are single-handedly keeping fax machines in business. That's not a way that we can effectively address public health infrastructure. And then thirdly, we need development of our public health labs. We need to have personnel in those labs, work experience personnel. We need to develop the capacity. We need to have machinery so that we can develop our public health labs. They are the ones that detect the disease. They are the ones on the forefront of doing that. In that context, I believe that not only do we need one-time support, but we need longitudinal support in order to be able to maintain that infrastructure so it's ready to go for preparedness in future pandemics. And then, of course, we need to work through global health security as well. Thank you.
Thank you, Doctor. Dr. Fauci, one of my colleagues asked you about AstraZeneca. One of the big issues that people have already mentioned is the whole, people not wanting to take the vaccine. There was a recent poll done that showed almost 50% of Republicans questioned said that they were not going to get the vaccine. I'm not trying to turn this into a political thing. I think it's a good thing that Donald Trump admitted that he got the vaccine in January. But my concern is that when people are just kind of loosely hearing about what's going on with AZ outside of the U.S., how that's going to contribute to an increase in people's fear of taking the vaccine, even though it has nothing to do with the vaccines that are presently being given here in the U.S. And how can we address this issue of people having doubts about the vaccine once and for all? Or is there a way to do that?
Yes, thank you for that question, Congresswoman Rice. There is a way, and in fact, we have been very active in outreach to the community to try and get the evidence and the data that are correct to individuals. And that's the reason why literally all of us on the team, the White House medical team, are out one way or another, be it with minority populations or just people in general, explaining the facts about the vaccine, talking about why and how it was shown to be safe and effective. Often people don't appreciate that the process of showing that a vaccine is safe and effective is really determined the data by an independent data and safety monitoring board that does not behold to the administration or to the pharmaceutical companies, but it's made up of independent scientists, vaccinologists, ethicists, and statisticians. When they determine that the data show that it's safe and effective, then the FDA makes a decision, but they also are very closely related to their own advisory committee. So the entire process is both transparent and independent. And we explain that to people and take the time to address their hesitancy without being confrontative. We are getting better and better and getting more and more people who now are willing to take a vaccine. And we're just going to continue to do that.
Well, I'm glad to hear that, Dr. Fauci, but all of this scientific-based information is being heard in an echo chamber of mis and disinformation, which makes your job even harder. Very quickly, Dr. Fauci, you were asked before about the long haulers. My concern, and I think we should all be concerned about this, is the long-term health implications. So everyone knows someone who had this disease. A brother of mine had it. His symptoms were pretty mild, but they are still there. So what are the long-term medical implications and long-term health implications for people who have COVID, whether they had it a mild symptom, moderate, or were more severe? Well, what are we going to do about that?
First of all, we've got to determine the extent of it. There are two types of long-term concern. There's an individual who might get mild to moderate symptoms, may or may not be in the hospital, and winds up getting unexplainable symptomatology like fatigue, like some of the symptoms that I just mentioned in response to another question. But there are also those who get considerable organ system damage. I made rounds myself on a patient about 4 days ago at the NIH Clinical Center where the extent of disease that person has, that even if they do recover, almost certainly they are going to have prolongation of dysfunction in multiple organ systems. So it's not only the long COVID, it's also people who have damage to their heart, to their lungs, to their kidney. Those are the things that we are also concerned about.
Thank you, Doctor. Thank you all.
Chair now recognizes Mr. Burgess for 5 minutes.
I thank the chair. Dr. Fauci, let me just ask you a question in reference to some comments that Chairman Pallone made during his opening statement about the lack of a national effort. Would you consider Operation Warp Speed to be a national effort?
Yes, it was a national effort that was started, we were part of it at the NIH. The CDC was part of it. The FDA was part of it. Yes, it was.
But long and short, if there was a national effort, and even on the effort on PPE, Operation Airbridge was a national effort, was it not? You were part of the White House task force at the time.
That attempted to address a very severe shortage of PPE, yes.
But it was a national effort. I mean, you would agree with that.
Yeah.
But look, and you'll recall the very first hearing when Diana DeGette became chairwoman of this committee, the very first hearing, one of the very first hearings we had was on vaccine hesitancy. You came and testified at that committee. This was a year before anyone ever heard of novel coronavirus. So in your opinion, what can we best do to help you alleviate the problems of vaccine hesitancy?
Well, I think that there are many things that you can do. First of all, we've gotten from the Congress as part of the American Rescue Act the ability with more resources to be able to promote the dissemination and administration of vaccines. So I think that's really important what the Congress has already done. And I also think...
Let me just interrupt you for a minute, but even 3 years ago, the PR side of things, both at the CDC and the NIH, really seemed to be where the gap was. Are there things we can help you do on the public service announcements or the public relations side?
Well, well, Dr. Burgess, I think you just hit on something. I think maybe by example, if members of Congress get vaccinated, maybe even publicly, that would really be helpful.
Well, and I think a lot of us have, and certainly made that information public. Well, I just want you to know, going forward, we stand ready to work with you to do whatever is required. Yes, I too was grateful as the president said on Maria Bartiromo's show that he encouraged his supporters to be vaccinated. I think it is important. Let me just visit with you for a second about the structure of the purchasing contracts between the United States and some of the vaccine manufacturers. There was an option in those contracts. There was an option to purchase additional doses, was there not?
I believe so, Dr. Burgess. I was not directly involved in that, but I do believe there was an option there. But I'm actually speaking on shaky grounds here because I was not involved in the purchasing.
Do you recall just generally when those contracts were struck? Again, it is not something that I was involved with. It had to be very early in 2020, right after the operation. And that would be my point. It has been some time since those occurred. Dr. Walensky, thank you and congratulations. Thank you for making your first appearance before our humble subcommittee. As you can see, it's as I told you, it's nothing but sweetness and light when you get in front of this committee. I just had a question for you about when you testified before the Appropriations Committee, you had a 5-page report on the coronavirus vaccine distribution strategy and spending plan. And this was, I think, earlier this month in March of 2021. Was any of that drawn from the COVID-19 vaccination program, the interim playbook for jurisdiction operations? That was the date I have on this is October 29, 2020. Did you reference this background document to provide the data for the appropriations testimony?
Thank you for that question. I am certain that there are similar concepts that were considered at CDC in October 2020, as well as what we were considering in March 2021. Can I just go back to the question of vaccine hesitancy for one moment, if you don't mind? I just want to sort of articulate that I think we can't call vaccine hesitancy one thing. I think we should sort of acknowledge that there are many different kinds of vaccine hesitancy, some related to lack of convenience, some related to I don't necessarily want to be the one to go first, some related to, the science might have been developed too fast, or I'm worried about side effects, or nobody else around me has gotten it and I don't want to be the first one. So I think we have to address all of that hesitancy at its roots and understand where it's coming from, who's going to be the trusted messenger. So I think we among the efforts that CDC is engaged in is addressing all of those through vaccine confidence consults, for example. What is the issue that is leading to that hesitancy, and how can we help?
And I thank you for bringing that up. And Madam Chair, as in reference to that, I'd like to submit for the record a New York Times article from June of 2020 where they interviewed Dr. Zeke Emanuel, and his bringing up that the vaccine likely would not be able to be trusted because it will be delivered as an October surprise by the Trump administration. I'd ask that be part of the record.
All document requests will be considered as usual at the end of the hearing. Chair now recognizes Ms. Schakowsky for 5 minutes.
Well, first, let me thank our wonderful witnesses. We are all thankful for your work and the Biden administration's action to expand supply of COVID-19 vaccine to the American people. I just went to one of the super sites that's in my district, and it was fabulous to see. This is a great achievement in a mere 50 days since the president's election. But there is a looming crisis that has not been addressed sufficiently. The president has likened the battle against the virus being a war. And he is right. This is a world war. And as long as the virus flourishes anywhere, it is a threat to everyone, everywhere. And recently, the UN Secretary General, Antonio Guterres, has been quoted as saying the progress on vaccination has been wildly uneven and unfair, and more than 130 countries, he said, have not received a single dose. And that it endangers everyone. As the great Dr. Fauci recently said, I quote from, it was on one of the TV shows, unless you equally suppress throughout the world, you will always have the danger of a variant emerging, getting your country and reinvigorating your another spike. That is why poor and developing countries led by India and South Africa have, with hundreds of other countries joining in, have gone to the World Trade Organization asking for a waiver of the TRIPS agreement so that they can, during this pandemic only, be able to manufacture their own vaccines. So to Dr. Fauci and to Dr. Walensky, even if Americans are vaccinated, can we really be protected if other countries can't access a COVID vaccine until 2022 or 2023?
Well, thank you for that question, Congresswoman Schakowsky. You're right. I actually stand by what I said, and you quoted me correctly, that if we have outbreak and viral dynamic anywhere in the world, it's a threat to everywhere in the world. And that's the reason why I was so pleased, as one of the first things that President Biden did, literally the day after his inauguration, was to ask me to make a statement to the executive board of the World Health Organization that we were going back into the World Health Organization. We were going to be paying our fair share of our obligations, and we were joining COVAX, which is a consortium of companies and countries and organizations to do just what you're asking, to try and get equity among the distribution and the production of vaccines. In that regard, you're aware that we are giving $4 billion to COVAX, but we also know once we get our own country vaccinated, since we've suffered worse than virtually any other country besides Brazil, we're both way up there with over 530,000 deaths, that we will make any surplus vaccine available to the countries who have not the resources to be able to make it themselves.
Well, I'm just wondering if that's really the answer, just to give our surpluses when so many countries have asked for permission to create their own. And to Dr. Walensky, I know that you have had experience with third world HIV, AIDS impact, and I wonder if you could shed light on the danger to the U.S. Health and economy if we allow big pharma to dictate how we and when poor countries receive a life-saving vaccine, and that we focus on protecting, unfortunately, I think, intellectual property rights over getting the vaccine, to allowing other countries to produce it.
Thank you so much for that question, Congresswoman. You know, I think we just have to look at the last 4 pandemics or the last 4 infectious threats of our country to know that we are all in this together as a globe. If you look at H1N1 or Ebola or Zika or now COVID, anything that affects areas around the world is potentially a threat to us. Indeed, these variants, the ones that we're most concerned about right now, also started in outside countries. So I think we have to work as a nation
Well, I hope that we could, the U.S. could do all those good things, plus allow for this TRIPS waiver for these poor countries. And I yield back.
I'm now pleased to recognize Mr. Long for 5 minutes.
Thank you, Madam Chair, and thank you all for being here today. Dr. Walensky, the subcommittee held a hearing in February with a handful of states regarding COVID-19 vaccine distribution at the state level. In addition to highlighting the need for more supply, one issue the states noted was the need for additional transparency regarding distribution and for better understanding of how the doses their state would receive and when. Dr. Walensky, what is the current process to notify states about the vaccine allocation and distribution?
Thank you for that question, Congressman. I have been now on I've been on most of 8 governors' calls once a week on Tuesday mornings where Jeff Zients and I are discussing not only the state of the pandemic, but the plans for vaccine distribution. Among the things that was promised to the governors is that they would have a 3-week line of sight as to how much vaccine would be coming so that they were able to plan for the vaccine allocation in the weeks ahead. So those happen weekly, that allocation happens weekly to the governors. I also want to note that there's a supply that goes directly to the states, and then there's also allocation that goes to FEMA for these community vaccination sites that Congresswoman Chakowski mentioned, to federally qualified health centers, as well as to the federal pharmacy program, and then, of course, to federal agencies such as the VA, the State Department, and DOD.
I know that, as you mentioned there, President Biden said that the states would receive 3 weeks' notice, and did I hear you right? That is currently happening?
Indeed it is.
Okay, that was a big step and a huge improvement, and I'm glad that they're following through on that, because I know the states desperately needed that information. Dr. Walensky, what can the CDC and other parts of the federal government involved in the distribution process do to increase transparency for the states?
So we are working with the states to ensure where that supply goes, to demonstrate what is happening in our vaccination supply system through systems like Tiberius that show where the federal pharmacy programs are getting distribution, to see where the community vaccination centers are going to land. As well as to work with the states towards vaccine confidence and to provide resources for health equity as well.
Again, Dr. Walensky, it is critical that we ensure Americans have access to COVID-19 vaccines regardless of their geography, regardless of where they live. Dr. Walensky, what is the CDC doing to ensure that Americans who live in rural areas, such as I represent a lot of rural areas in the United States, have access to the COVID-19 vaccine?
That is such a key question. Thank you for that. We have put 10% of the initial $3 billion into issues related to health equity, as well as to outreach towards urban centers as well as rural centers. The federal pharmacy program is among those designs. So as you may know, the federal pharmacy program is now distributing to 9,000 pharmacies with the goal to scale up more than twice that. And those pharmacies are actually placed with the experience that we have from CDC and vaccine distribution in place. The pharmacies are chosen to reach these hard to reach populations, including rural populations, these community pharmacies, small chains as well as large chains. And 90% of Americans now live within 5 miles of a pharmacy. So that's among the ways that we're using that program, as well as federally qualified health centers to address marginally housed populations, non-English speaking populations.
Okay, well, thank you. And about a month ago, I set out on a 3-day tour. I just cleared my calendar for 3 days and visited 6 hospitals, 2 clinics, and 1 vaccination center in my district. And I wanted to sit down with the frontline workers, the doctors, nurses, people that have been dealing with COVID patients for a year now. And back at that time, my phone lines were burning up. People were concerned where they could get the vaccine. I'd go to one hospital, and they were supposed to receive the vaccine that day, and they did not. And other hospitals got Pfizer, and then they said they couldn't get the second dose of Pfizer. But I just want to say, and thank all of you that have contributed to this in any way, shape, or form, that my phone lines have settled down. People seem to be able to access the vaccine a whole lot better than they could 1 month ago. And with that, I yield back.
Thank the gentleman. Chair now recognizes Mr. Tonko for 5 minutes.
Thank you, Madam Chair. In less than 2 months in office, the Biden administration has moved swiftly to dramatically expand our vaccine supply. But as we all know, vaccines sitting in vials don't protect people. Vaccines in arms do. I am appreciative of the leadership that all of our public health experts today offer, those that are here as our witnesses. When can we expect all American adults to be fully vaccinated, and when can we hopefully achieve herd immunity? So, Dr. Walensky, President Biden will direct states to make all adults eligible for the vaccine by May 1st. The Biden administration also believes that we will have enough vaccine doses for every adult by the end of May, 2 months earlier than initially forecasted. But it is unclear how long it will take to actually get those shots into arms. So we know that states are responsible for administering vaccines and for prioritizing vaccine allocations. What mechanism is the administration using to direct states to make all adults eligible for vaccines by May 1st, and how will that directive impact states' ability to prioritize certain populations?
Thank you for that question. Part of yes, we have a goal of herd immunity, and we're working to get there. When will everybody have vaccination? It really depends on how interested people are in getting vaccinated. So there has been a supply constraint until now. We're working through that supply constraint, and I think in the weeks ahead that supply constraint will diminish, and then we're really going to need to do the hard work, as you note, to work towards getting vaccine in places that it hasn't touched yet. There are places that have been hard to reach communities, hard to reach places, tribes, rural places, urban sites. So that is the work that we have ahead. It's hard work that we have ahead. We have to cross the digital divide and make sure that people are not just able to sign up through electronic systems. We need to make sure that people have phone banks. We need to spend resources, and we're already working in this space with community-based organizations, faith-based organizations. We need an educational campaign. We need, and so we've been actively working in that area, and that is among the resources that we're going to put forward in the American Rescue Plan.
Thank you.
If I might just mention one thing, if I could, with your permission, we really need to be careful about this elusive terminology of herd immunity, because we really do not know what percentage that really is. And I think we should focus on the fact that whatever vaccine we can get into people will get us closer and closer to the protection of the community, going between 2 and 3 million doses per day, rather than concentrate on this arbitrary percentage that it could be anywhere from 70 to 85%. We just don't know yet. We should focus on getting as many people vaccinated as quickly as we possibly can. I just wanted to make that point because people get hung up on that terminology, which could not be, I think most of the time is not helpful. Thank you.
Yeah, and Dr. Fauci, while you've made comment to that, what effect do we have on that herd immunity achievement when we consider that children under the age of 16 are not currently eligible to receive any vaccine?
Yeah, again, it gets back to what percentage do you mean is herd immunity? If you subtract the number of people, the number of children less than 16 from the population, and you make an arbitrary percent, you may not reach that percent until you get the children vaccinated. That's the reason why I say, rather than focusing on that, let's just keep pushing to get as many people vaccinated as we possibly can. And as we do that, you will see the type of infection, the dynamics of the outbreak get less and less and less. So whatever that time is, middle of the summer, end of the summer, early fall, we'll be much, much better off than we are right now.
Thank you, Dr. Fauci. And Dr. Marks, the Biden administration has now purchased more vaccine doses than required for vaccinating the entire U.S. population. Experts believe we may soon have greater supply than demand. After every American is fully vaccinated, what are the administration's plans for the extra vaccine it has purchased? Is there a structured plan to reach out to others?
I'm going to have to defer that to the vaccine people who are actually distributing the vaccine at FDA. I can say that one piece of insight I can give you is that there may be some concern that we have enough vaccine that if we need to give boosters in the not too distant future, that we have sufficient supply to be able to do that, because we still only know that the vaccine has a certain length of protection, probably at least 6 months, but we don't know whether that's a year or more. So there may be some wisdom to having some supply, but I'd have to defer to others in the administration about what will happen with additional supply, whether it will go overseas or whatnot.
Okay, thank you. Any comment from any of our others? Or?
The gentleman's time's expired, and I'm trying to make sure everybody can ask questions before our panel has to leave. So thank you. Mr. Joyce, you're now recognized for 5 minutes. You'll need to unmute, Mr. Joyce. Thank you.
Thank you, Chair, and thank you, Ranking Member Griffith, for convening this group today. Dr. Fauci, it's great to see you again. Years ago, I sat when Dr. Tom Provost, my chairman at Hopkins, brought you there to lecture us, and you've continued a career that has had impact throughout the decades. Dr. Fauci, I have two separate questions that I think will really have you reach into the skill set of immunology, which is one of your many areas of forefront. As we continue to see advancements in second-generation vaccines, do you believe that innovations such as intranasally administered vaccines, those that allow the development of IgA or mucosal immunity, do you think that those should be considered as we reach to the next step of vaccines?
The answer to that is yes. I mean, there's a lot of interest, and there always has been, about exposing mucosal surfaces against vaccines that are essentially transmitted through the respiratory route. So you're right. This will be the second and third generation vaccine, and there's research already going on that we are supporting at the NIH level. So I would imagine that you are going to be seeing, after we get this all under control, I don't think, as you probably know, it's not going to be ready to essentially get the pandemic under control. But we're going to have respiratory illnesses that are essentially emerging in pandemic form for years and years to come. And we may be having to deal with SARS-CoV-2 for more than just the next year or so. So you're quite correct, Congressman Joyce, that those type of innovative approaches towards vaccine are definitely on the table.
Dr. Fauci, as we look to possibly address the lack of adequately immunizing pediatric patients and the risk wards with certain current vaccines, should we be looking at less invasive methods of vaccine administration, specifically the intranasal route? And I'm going to use the analogy of Jonas Salk, who developed the original polio vaccine in my home state of Pennsylvania. But I didn't receive the Salk vaccine as a child. I received the Sabin, the oral vaccine, where we were lined up and taken to school and received it on a sugar cube. So when we address parents' hesitancy to immunize their children, is there a role for the intranasal route as it continues to be developed?
The answer is yes, the same answer to what you had mentioned to your first question. You recall that this is something that we faced with influenza when we developed the flu mist, which was originally designated for children, originally saying that you don't want to give children an injection because they may not like it. It turns out, from an immunological standpoint, it also had some value added there. So the answer to your question is yes, we will be pursuing alternative methods of administration of vaccines, both for SARS-CoV-2 as well as for other diseases.
Thank you, Dr. Fauci. Dr. Walensky, my next question, and we've addressed this in some levels in earlier questions, But we realize that there's a vulnerable population, approximately 500,000 individuals in the United States who suffer from kidney failure and are going hemodialysis 3 times a week on a regular basis. And a lot of these patients, actually, I think the estimates are close to 90%, have multiple comorbidities like diabetes and hypertension, and they face a 20+% mortality rate if they contract COVID. Unfortunately, they remain largely unvaccinated. And considering these are high risk and we want attention to health equity, what are your steps for bringing these vaccinations to these patients who are going to hemodialysis centers 3 times a week, have a great support staff providing that hemodialysis? What next steps should be taken to allow the immunization of these patients who have kidney failure and allow their workers, those who participate, the technicians who provide that 3 times a week hemodialysis, what steps should be taken? Should that immunization occur right at their dialysis centers?
Thank you for that question, Dr. Joyce. Yes, we are actively working now. You know, of course, we had supply constraints early on, so we couldn't roll out all programs that we wanted to early on. But right now, we are actively working with dialysis centers. As you note, not only is this a high-risk population, but it also is often a minority population. And so this is a key place where we could offer a vaccine. It's a trusted resource. People come 3 times a week. And in fact, we're actively working with these dialysis centers to roll out a plan for vaccination there.
Thank you. I see my time has expired, and I thank you for your presentations.
I thank the gentleman. Chair now recognizes Mr. Ruiz for 5 minutes.
Thank you, Chair. We have been talking for months now about the importance of making sure that there is an equitable distribution of vaccines, that we need to make sure people are prioritized based on level of risk for contracting and dying from COVID, and not solely based on their income or ability to purchase the vaccine. And while the guidelines put out by CDC do prioritize the higher risk groups, what we are seeing is that despite these efforts, we have an access problem in the hardest hit communities that are traditionally underserved. Qualifying for a vaccine doesn't help if you can't actually get one. And targeting populations who are at higher risk has not always translated to those populations getting vaccinated. Underserved communities with higher rates of infections have disproportionately low inoculation rates, as do individuals of color, despite the fact that they are more likely to contract COVID-19, transmit COVID-19, and die from COVID-19. According to a recent Kaiser Family Foundation report examining data from 35 states, the vaccination rates among white people was over 2.5 times higher than the rate for Hispanics and nearly twice as high as the rate for Black individuals. And I'm seeing this play out in my own district. In Riverside County, California, where my district sits, Hispanics make up 47% of the population, but 65% of COVID cases. Yet, Hispanics have only received less than 19% of the vaccine, which is why I applaud President Biden's focus on equity by getting vaccines into the communities that are hardest hit. First, the federal retail pharmacy program was a good move because they exist in almost every community. And second, providing vaccines to FQHCs ensures that medically underserved areas have vaccines for their high-risk residents. But we also need to make sure that the FQHCs and the retail pharmacies are opening vaccine sites in the underserved communities. We need to make sure to address barriers like lack of internet to make appointments, lack of transportation to the vaccine sites, lack of time away from work, lack of information in a language people understand. Equity does not mean equal. It means providing resources proportionate to the need or burden of disease. Equity requires 1, prioritizing high-risk individuals and communities, 2, allocating vaccines proportionate to those risks, and 3, vaccinating people in the community with community partners or at the workforce. And because of President Biden's equity initiative, I was able to partner with Rite Aid and local community health workers or promotoras, the Desert Healthcare District, and the Coachella Valley High School to inoculate over 700 people in 2 hours for the hardest hit, highest risk communities at a vaccination site at the high school. I also partnered with Eisenhower Health to vaccinate 577 people at Coachella Senior Center, also a medically underserved area. Dr. Walensky, the Biden administration has taken steps to expand vaccine access through direct distribution to these retail pharmacies. What is the plan to ensure that the vaccines are mostly being offered in retail pharmacies located in communities hardest hit, like medically underserved areas or communities of colors, and not just in low-risk, affluent cities as reward for their higher consuming customers?
Thank you so much for that question, Dr. Ruiz, and thank you so much for your leadership and the inspiring work that you are doing to make sure that this vaccine is reaching these hardest hit communities. Our group at the CDC, our pharmacy group at the CDC, has really wonderful connections with these pharmacies through vaccine distribution and flu vaccine as well. They know where these pharmacies are, where the local pharmacies are, where the hardest to reach communities are, and which pharmacies are there. And we're collaborating with the administration to make sure that it's those pharmacies that are getting vaccine. I also want to comment on the community vaccination sites. We are collaborating with FEMA, and we picked the sites for these community vaccination sites, these 6,000 a day vaccination sites, to ensure that they are in areas both of high census as well as high social vulnerability index, greater than 0.7. So we are actually specifically selecting these sites for exactly those reasons. Finally, I want to say that one thing I believe is really important is that our efforts here are sticky. And the way that I mean that is to say we can't be one and done as we do this outreach, because as soon as we get all of these communities vaccinated, we need to make sure and go back and get their children vaccinated for their missed childhood vaccines. And we need to work on hypertension. And we need to do so many other things in these communities to address health equity after COVID-19.
I thank the gentleman. Chair is now pleased to recognize Mr. McKinley for 5 minutes.
Thank you, Madam Chairman. And Dr. Walensky, speaking of the misinformation being disseminated that Catherine McMorris-Rogers brought up earlier, my Twitter account has been lit up during this hearing by people posting that President Trump killed 500,000 Americans. So, Dr. Walensky, would you agree with that statement? Is that an accurate statement that Trump killed 500,000 people?
Thank you for that question, Representative. I came into this office in 2020, and on January 20th, and came into this administration on.
It's a yes or no, Dr. Walensky. Did he or did he not kill 500,000 people?
I think the effect of this pandemic is multifactorial.
Sure. Oh, I can see where this one's going to go. So, Dr. Fauci, if I could turn to you, since she's not going to answer the question. Well, on the campaign trail, we heard time and time again from the then candidate Biden that the president's words have consequences. Then on Monday, the National Review reported that President Biden proclaimed that Americans should wear masks until everyone is vaccinated. Now, I'm not aware of any healthcare professional expecting that 100% of the population will be vaccinated. So, Dr. Fauci, do you agree that Americans should wear masks? Do you agree with the president that Americans should wear masks until 100% are vaccinated?
You know, I'm sorry, Congressman McKinley. I did not hear that statement, and I pretty much follow what the president says. I didn't hear him say that everyone should wear masks until 100% of people are vaccinated.
He said until everyone is vaccinated. He didn't say 100%. He said until everyone.
Well, everyone is 100%.
That's what I thought so too. So I'll tell you what, Doctor, I'll send you a copy of that. It was on several news outlets about that, but it first broke on National Review. Let's go back to try to get a straight answer from Dr. Walensky. Dr. Walensky, regrettably, 288 children have died from COVID, according to the CDC. And that's a tragedy by any measure. But that number actually mirrors the annual deaths due to seasonal flu with children. So at the beginning of the pandemic, we closed schools, and we understand that. We didn't know the effect COVID could have on children and teachers. But now we know. So the data suggests the spread of the virus is minimal in schools that use safety precautions, even in communities with high disease prevalence. And teachers are being vaccinated. So college students can go on spring break, and bars and restaurants can open up at full capacity. But children can't go back to school, and people cannot attend church services. Dr. Williams, communities and states are looking to the CDC for guidelines. Will the CDC be updating their school reopening guidance this week regarding giving the new data available?
Thank you very much for the question. We recognize the challenges of having children home. I want to articulate that, respiratory viruses frequently travel in schools, and I think we were cautious when we had a respiratory virus, and we were worried, like influenza, that this virus might behave in the same way. We published operational guidance to get children back. In fact, it was intended to have schools lean in to get the schools that were closed open, and we very specifically said that schools that are doing well should not close. And so now we have emerging science that looks at the 3 feet versus 6 foot rule.
Okay, thank you. So are you going to be, so if I've got one last question that I don't need to be filibustered on. Dr. Fauci, last summer, while the pandemic was raging, we also had social unrest, unfortunately, happening in the country. Thousands of people, understandably, were gathering to protest racial injustice. The media and some public health heralded these protests. In fact, 1,200 public health professionals signed an open letter arguing that protests against systemic racism must be supported, quote, even at the cost of spreading the virus. Dr. Jennifer Nuzzo of Johns Hopkins stated publicly, quote, public health risks of not protesting exceed the harms of the virus. Dr. Fauci, do you agree with that statement?
My stance has always been that we should abide by the public health measures that we talk about all the time, which is avoiding congregate settings, wearing a mask, washing your hands.
So you would think that they maybe weren't justified?
I'm not going to get into the justification or not of who demonstrates about what. I'm just going to give you the public health measures that we talk about all the time and not get into the background or basis of a demonstration or not.
Thank you. Thank you.
Yield back. Expired. Chair now recognizes Mr. Peters for 5 minutes.
Thank you, Madam Chair. I wanted to follow up a little bit on my colleague, Dr. Ruiz's questions about equity. Equity is a key tenet of the Biden administration's national COVID-19 strategy. And so I know that the Biden administration is taking great strides to expand distribution by setting up 20 high-volume federal vaccination sites, which support 600 community vaccination centers, increase the number of community health centers and retail pharmacies, as we were discussing before, offering vaccinations in underserved communities. But I'd like to ask Dr. Walensky, maybe in a more open-ended way, can you explain how the administration determines, first, the location of these vaccination centers, and second, the number of doses to deliver to each jurisdiction? What are the basic factors that go into those determinations?
Thank you for that question, Congressman. The CDC works collaboratively with FEMA to find areas of high census and areas of high social vulnerability index as to best places to place these vaccination centers, as well as what volume they need, whether that area would support a 6,000 dose a day or a 3,000 dose a day vaccination site. As to how many doses and how that allocation happens, that happens at their operation level. And so, I can't speak exactly to how that occurs. We assist in the site selection.
Okay, well, I appreciate that. I would like to ask you, Dr. Walensky, too, a little bit about data. I'm very concerned about the quality of data. I think all sorts of federal agencies touch the data that comes in that's reported from states, and there's no standardization for how you report data from state to state, maybe even from hospital to hospital. So it makes it very hard for you and for us as policymakers to really understand what are the facts on the ground from which we can make policy decisions and how you can respond to this pandemic and maybe future health crises like this. So I want to know, first of all, what guidance have you developed for state and local governments on on like what data to report, whether you would standardize that, how are you dealing with the various silos in the federal government, and then also maybe you could touch on how the federal government protects the privacy of the data that's reported.
Thank you for that question. I think among the things that you're highlighting is that our data infrastructure was actually not well supported when this all started. And in fact, we are working hard on data modernization efforts so that we can ensure that data is coming there. That we have to provide independence to the state so that they can report as they are able, but then also some uniformity of data so that we can actually receive that data and report at a national level. So we are working closely with the states to unify the data coming in and to act, as well as data modernization efforts in the context of this pandemic. I want to articulate that CDC does not receive individual line item data from individual persons. So we keep that, the privacy is held at the state, and we get data on aggregate unidentified.
Sure, but you'd agree that, that if we don't standardize the reporting and we don't have an understanding about hospitalizations and pre-existing conditions, for all the various people who are experiencing it, it makes it very hard for us to judge what's really going on the ground with accuracy. Is that right?
I think we have, a lot of individual states have had to develop their individual data systems, and we need to provide some independence for them to be able to do that, and then some uniformity in reporting.
Yeah. I'm trying to help you with the uniformity side. We've actually introduced a bill called the Health Statistics Act, in consultation with a lot of the statisticians in Washington who think this is really important. I'd urge you to ask about it. A lot of this can be implemented by the administration without Congress, but part of our effort is to provide financial support to local and state efforts to report these data to the extent they have to change their systems for reporting. So we would like to help you with this at the committee and hope that you'll take us up on that. And I guess finally, just to track our, maybe just to follow up on one more equity issue, since implementing the health center program, has the administration observed an increase in the rates of vaccination among Black and Hispanic Americans, and how does that look going forward?
Right. We know that the Black and Hispanic population had a larger life expectancy loss, a higher death rate, and so we are working actively to make sure, we have 10% of resources, of vaccine distribution resources, going to ensure health equity. We have worked on vaccine confidence consults. We're working with NGOs and community-based organizations to make sure that the message gets to trusted messengers. That's exactly the hard work that we have ahead.
My time's expired, but I'd asked whether we'd seen the vaccinations go up among those populations.
We are dedicating a whole lot of effort to that, so I would be surprised if that's not the case. That's fully engaged. We're fully engaged in that activity. That's what we need to do.
I thank the gentleman. Chair now recognizes Mr. Palmer for 5 minutes. Mr. Palmer, you seem to be muted. See if that works. No. Mr. Palmer, we still can't hear you. I'm going to go to the next member and then we'll come back to you. So Ms. Schreier, you're now recognized for 5 minutes.
Thank you so much, Madam Chair. First, thank you to all of our witnesses for your tremendous leadership. Now today, I'm not speaking as a member of Congress, I'm speaking as a doctor. I told my own parents that when they go for their coronavirus vaccine, they should take whichever one is offered because they all prevent hospitalization and death essentially equally. So just to be very clear, Dr. Fauci, doctor to doctor, would you agree?
I would agree totally with what you told your parents. Absolutely. We have 3 highly efficacious vaccines. And importantly, as you correctly told them, they are all 3 of them superb at preventing hospitalizations and deaths. So whatever you told your parents was correct, doctor.
Thank you very much. Now, I also have concerns about where we go from here. Like, as long as this disease is circulating anywhere in the world, we remain at risk. And I'm worried that with variants popping up pretty quickly, this virus could get ahead of our vaccines. And so far, we've been lucky, but we don't want to end up playing whack-a-mole every time there's a new variant. And so I want to make sure that we don't get caught off guard by some new variant and without the tools we need from a public health standpoint. I want to make sure that our return to normalcy is sustained and that we don't have to fully close down our economy or our schools again. So if COVID's going to be with us for a while, vaccination is critical, but I also believe we need a much greater ability to test asymptomatic people, test them early, catch them early, and prevent outbreaks that could land us right back in the same situation. So, for example, if we had widely available, inexpensive home testing, people could test themselves and stay home if they're infected. I'm thinking schools, workplaces, and we could catch the disease early and prevent outbreaks. So, Dr. Fauci, do you agree it would be useful to add some degree of routine home testing in addition to vaccinations to our public health toolbox?
I not only agree with that, Dr. Schreier, I actually have been saying that for months and months and months, that we should be literally flooding the system with easily accessible, cheap, not needing a prescription, point of care, highly sensitive and highly specific, that we could do just what you are saying. And then, in fact, you're going to be seeing more of that soon.
That's great. You and me both, Doctor. And Dr. Walensky, our children won't be vaccinated for many months. Could you just comment briefly on how home testing could help schools not only open safely, but stay open?
Thank you for that, Dr. Schreier. I too have been saying that and writing about it as well. You know, we know in schools, we know now that we didn't know then, that children, there's less transmission in schools among children as there are among adults, between adults. And so I do believe once we have teachers vaccinated that we can use testing in the schools, serial testing, cadence testing to identify potential infections, asymptomatic infections, shut down clusters, and be able to keep our schools open.
That's right. I'm even imagining that you wouldn't have to quarantine a whole classroom. You could just test everybody every day and root out the ones who are infected. So finally, I know that a lot of these tests are in the pipeline and saw yesterday that there is a new path for evaluating these kind of tests to use at home, but we haven't seen the same sort of push to get them produced inexpensively and at scale and into everyone's hands the way we saw with vaccines. And so I would just ask the three of you, one at a time, would the three of you commit to working together in kind of a whole of government approach to get these tests into every home as quickly as possible?
Absolutely. Absolutely, Dr. Schreier. And in fact, in one of those tests that recently came out, we're investing a couple of $100 million to really scale up the production to do just what you're saying. But I agree with you. We need to do it on a broader scale, not just for an individual product.
Great. Dr. Walensky?
Indeed, and we're working towards imminent release of guidance that will facilitate this.
I love that. Dr. Marks?
Yeah, so indeed, yes. Although I'm not responsible for devices, I can tell you that our Center for Devices is doing whatever they can to expedite the availability of these as much as they can.
Fantastic. Well, thank you very much. I really appreciate all of you being here, and I yield back the rest of my time.
Thank the gentlelady. Mr. Palmer, welcome back, and you're recognized for 5 minutes.
Can you hear me now?
Yes.
Oh, you're nodding. Okay, I expected a verbal response. Dr. Fauci, during Dr. Joyce's comments, the two of you discussed the flu mist for young children. And there's research that the preclinical trials were done at the University of Alabama, Birmingham, with a company called Altimmune that is developing an intranasal delivery that I think has tremendous potential because it's not only a vaccine, it also prevents transmission, or at least it's in the clinical trial to determine whether or not it would prevent transmission. My question to you is, what do you know about that approach and the potential for for helping us to reopen our schools, not only our schools, but our whole country.
Well, intranasal application of vaccines for respiratory illnesses do have an advantage, as I mentioned in my answer to a prior question. You bring up a very good point. If you induce a high degree of mucosal immunity, that since viruses are transmitted from the nasal passage and the lung and the mucosal surfaces, that could have the advantage. We have been investing at the NIH not only in products such as you described, but a number of our grantees are working on alternative methods of vaccine delivery, and the mucosal presentation of the vaccine, either through a nasal spray or even an oral version of it, is being pursued by a number of investigators. So the answer to your question, Congressman Palmer, it is a very favorable and promising area of research.
I think, too, particularly because it doesn't require cold storage, it really helps us with the distribution in rural areas and to some of these disadvantaged communities. And then there are people out there who are needle adverse.
Right.
I resemble that remark, but that I think this could be a very effective program. My question is, and you may not know the answer to this, are these trials are part of Operation Warp Speed?
The Operation Warp Speed is not one that, in essence, is doing additional trials other than a group that we have put together, the 6 companies, 3 platforms. Trials that you're talking about would fundamentally be funded at the NIH level or the CDC level in certain circumstances.
I would think, though, given the potential efficacy for this drug for preventing the transmission, that it ought to be part of some type of Operation Warp Speed program to get this done as quickly as possible, and particularly for getting kids back in school. Last thing that I want to point out, I do appreciate the fact that I don't know if you were part of the study or supported the study that was done in Massachusetts that showed that allowing the students to sit 3 feet apart and the staff to be 3 feet apart did not increase the rate of transmission. And I think that's a very important study. More people need to know about it in terms of getting our schools reopened.
Yeah, the CDC is very well aware of that. In fact, Dr. Walensky just commented to that over a little bit ago. So, Rochelle, why don't you repeat that?
Yeah, thank you for that question, Congressman. You know, when we put out our guidance, one of the hardest things that we recognized for schools to be able to do was the 6-foot distancing. And whenever there are challenges, that's when science emerges. So right after that guidance came to, then there were studies that were ongoing that looked exactly at the 6 feet versus 3 foot question when people are 100% masked, as they were in Massachusetts. That study was released just late last week. I'm aware of several other studies that are emerging, and when we have concise and consistent evidence that we are actively reviewing actually right now, we will update our guidance. Thank you.
Thank you. I do want to say something to you, and I rarely do this, but I was offended and extremely disappointed that you couldn't give a straight yes or no answer on whether or not the claims that President Trump was responsible for 500,000 COVID deaths, when you've got over half the deaths in Pennsylvania are in long-term facilities. I mean, there are people that would blame Governor Cuomo for the 15,000 deaths in long-term facilities. I just think that's unfair, and it's in my opinion, beneath the office that you hold. And I would really appreciate if you could give a straight answer, yes or no. Is President Trump responsible for 500,000 people dying from COVID?
I'm going to intercede right here. I'm going to let Ms. Walensky answer, but I as chair, we're going to let her answer that question that has now been asked by 2 people. If you could do it quickly, because we're running up against your time frame. Go ahead.
Thank you, Madam Chairman.
Thank you. Thank you, Congressman. I think we have to look back. We will look back at this pandemic and recognize that there are many, many reasons why we as a country were ill prepared to tackle this pandemic that resulted in over 500,000 deaths.
It's not an answer.
Okay, that's that.
Thank you very
much. And we're not going to have any more badgering of the witnesses. Ms. Trahan, you're now recognized for 5 minutes.
Thank you, Chairwoman DeGette and Chairman Pallone, for holding this critically important hearing. My thanks to each of the witnesses. Look, your steadfast leadership and dedication in combating the pandemic has been critical to our crushing the virus, and a comfort to our constituents that better days are ahead for our country and for the world. I so appreciate you taking the time to appear before the committee. You know, as a mother of 6 and 10-year-old daughters, I'd like to continue to understand the impacts of COVID on America's children. Although they may be less likely to experience severe symptoms from COVID, we shouldn't minimize the fact that many have suffered very real harm over the past 12 months. And, you know, to no one's surprise, the same COVID-related health disparities suffered by Black and Hispanic adults have also befallen children of color. It was indicated earlier in this hearing that high school-age children might be able to start getting vaccinations this fall, and younger children will get vaccinated by the first quarter of 2022. In the meantime, many families across the country are anxious to return to pre-pandemic activities, and as adults line up for their vaccinations, they're craving guidance on how to live, work, and socialize while we wait for our children to get vaccinated. Dr. Walensky, let me just start by saying that we are so proud back home to have you at the helm of the CDC. Thank you for your tremendous service to all of us in Massachusetts and now to our entire nation during these unprecedented times. As the vaccines clinical trials among children continue, more adults become fully vaccinated and states begin to loosen restrictions. What do parents need to know about the ongoing risk to their kids from the virus? Specifically, is there guidance other than mask wearing and social distancing that you can give or that might evolve for vaccinated parent and grandparent interactions with children under 18 awaiting the vaccine?
Thank you for that, Congresswoman. You know, our initial guidance that what can you do when you're vaccinated was really a first step into recognizing that, in fact, there are going to be relatively low-risk children who want to see their vaccinated grandparents, and those children are going to be unvaccinated. And our guidance actually permits that as long as children don't have a high-risk condition and their family members don't have a high-risk condition. Among the things that we really need to recognize is that as we want to lean into more of our day-to-day activities, school sports is a really common one to discuss, that so much of how we are able to do that depends on how much disease is in the community. Because, in fact, that disease comes in from the community into the schools. We have numerous MMWRs that have been published on football outbreaks, on outbreaks that are happening in these extracurricular activities, and they happen when there's enough disease in the community and we're not taking these mitigation efforts. So I think what's going to happen is as more and more adults get vaccinated, we will see, I hope, and as we do it quickly, the community rates come down, and our ability layered on top with screening strategies, as was previously noted by we'll see, I hope, and as we do it quickly, the community rates come down, and our ability layered on top with screening strategies, as was previously noted by Dr. Schreier, to be able to engage in some of these day-to-day activities with our children.
Great, thank you. I also want to just touch on the mental health of our children. Others have mentioned it already today, but there is an urgent need to invest and strengthen mental health resources and services to our youth, and the pandemic has only exacerbated this. The CDC recently found that compared to 2019, mental health-related emergency room visits increased 31% for children between the ages of 12 and 17 from March to October of last year. I recently partnered with Congressman Cardenas to introduce the Youth Mental Health and Suicide Prevention Act, which sends funding directly to school districts to support positive mental health promotion and suicide prevention efforts in high schools. But the numbers show that our children need help right now. So Dr. Fauci, with our remaining time, what efforts are currently underway within NIH and across the broader federal government to understand and respond to youth mental health challenges that have been brought on or worsened by the pandemic?
Yes, thank you for that question. In fact, the Infectious Disease Institute that I direct is by no means the only institute that's involved in addressing a comprehensive response to the pandemic. The National Institute of Mental Health is now getting deeply involved not only in recognizing this problem, but by also trying to study its intensity and how we might respond to it. Your point is extremely well taken. We consider this one of the most serious issues related to spin-offs of the outbreak that really were not anticipated when you just think in terms of an infectious disease.
Well, thank you. The effects of the pandemic will be far-reaching and long-lasting. And I appreciate your being with us here today. We must be able to not only meet their needs now, but also in the future. Thank you. I yield back.
Thank you, gentlelady. Chair now gives the last word to Congressman O'Halloran, who's recognized for 5 minutes.
Thank you, Madam Chair. I appreciate the time, the work that went into this, putting this together, and I appreciate the panel, not just for coming here today, but for all the work that they've done over the last year to get us to where we're at today. The authorization of safe and effective COVID-19 vaccines gives America hope, but we must continue to follow the CDC guidelines in the United States. The variant first identified in the United Kingdom is spreading quickly, even as we have seen a reduction in overall cases. I want to be looking forward in the coming months as to how we can be prepared to respond to future variants and future diseases with the potential to turn into global pandemics. In the American Rescue Plan Act, Congress allotted $1.75 billion that will be provided to the CDC for SARS-CoV-2 genomic sequencing and surveillance. And there is a real urgency to this project, and we must become better at attacking new COVID variants and ensuring that variants that are potentially more contagious, deadly, and even resistant to variants do not spread. I have a number of tribes. They got tremendously impacted, and they have there's a lot of disparities going on both with tribes and throughout our country. We have to also address those issues quickly. And I want to thank Dr. Walensky on the work that she had remarked on the Navajo Tribal Utility Authority and the Navajo Energy and Construction Authority. Permanent solutions are needed in these areas. Yeah, I was going to ask a series of questions of different folks, but I want to use my time to identify we have to address this issue. But at the same time, the other viruses in the world or that may be coming are not going to stop because we're working on just this issue. So I want to ask each of the panelists, starting with Dr. Fauci, what do we need to do as a Congress? I don't think we can't afford to wait 2 years to start looking to the future. We have to do it now. So starting with Dr. Fauci, can you tell me, identify what do we need to do? How are we going to get there? And what does Congress need to do?
Well, one of the things that Congress has already done, Congressman O'Halloran, with the American Rescue Act and the extraordinary generosity of money that was put into that, is that there are components of that that are directed specifically to SARS-CoV-2, but will have spin-offs for long-term durable preparedness for pandemics of the future. In fact, as you continue to prepare and respond to what's going on right now, you're giving the building blocks of what we're going to be doing to have the structure and the capability of responding in the future. So they really are joined. So I want to just express my appreciation and all my colleagues at the NIH for the fact that this has been done, and this money will be extremely well spent looking forward.
Dr. Walensky, can you take that up? But I also want to say, that's what we've spent now. What are we going to be looking for in the future? We just cannot afford, just like a military process, we can't afford to be caught the way we were ever again. So how do we get to where we need to be?
Thank you so much. So let me echo the gratitude for the resources that we have received to jumpstart things now for the $1.7 billion for the variant genomic sequencing, as you note. What we need to do is lay the foundation now, and then we need longitudinal resources to ensure that we can keep that foundation both in the public health infrastructure, in epidemiology and data monitorization, as well as in global health leadership and global security, so that we can support global efforts, we can take global leadership, and we can create in-country capacity for our global health partners.
Thank you. And just quickly, how do you feel about the fact that we're where we need to go? What's the time issue here as far as, how soon will we get World Health Organization to work with us continuously, the other countries of the world to do that, and to make sure that we recognize the third world countries and the disparities in America and what has to be brought about?
Sir. Yeah, sorry. Well, we're doing it already because that's the reason why we went right back into the WHO. We're going to be giving the resources that have been held back, and we're joining COVAX. So we are already doing that. Dr. Walensky, you were going to say something.
I was going to echo exactly what you said. We're already working in 60 countries with over 150 projects. We're actively engaged with the WHO, and we've had long-standing partnership with them.
I would just, Madam Chair, I would just wish that everybody would bring the continuing work back to us, please, on a regular basis. Thank you, Madam Chair. Sorry for the override.
I think that that was the perfect ending segment for our questions, because it leads me to thank all three of our witnesses for being here and your wonderful testimony, your leadership on confronting this terrible pandemic in the last year, and your leadership as we go forward to vanquishing this foe, and also to looking to be able to address anything that comes forward. So we appreciate it. We know we will see you back again in front of this subcommittee. I want to remind members that pursuant to the committee rules, they have 10 days to submit additional questions for the record to be answered by witnesses who've appeared before the subcommittee. And I know all of the witnesses will respond promptly to any questions if you receive any. We do have one request for unanimous consent on a document. That's Mr. Burgess's request to insert an op-ed from the New York Times dated June 8, 2020. And without objection, it will be ordered. And with that, thanks again to our witnesses and all of the members who stayed, and the subcommittee's adjourned.
Thank you, Madam Chair.
Thank you.